Good afternoon. I think there are two speakers. One more, somebody is talking
Yes,
on
yes.
the knee.
So you are going to talk about the spine first, and Dr. Sanjay is going to talk about the knee first.
Yeah.
And the rest of the audience will decide what is to be done.
So, two degenerative conditions, lumbar canal stenosis and the knee osteoarthritis. Many times they exist in the same patient, and most of the time it is there. Severity may be different. Now, when patient develops both the condition and both needs a surgery, then the question is which one to do first. Let us do spine first. All spine surgeon will prefer to do a spine first. And if you talk to the TKR person, your orthoplastic surgeon, he will say, I will do the knee first. So it's a confusion. Who is going to do first surgery? So let us have one example. This is the patient with a 60-year-old female. She's a known case of osteoarthritis knees with LCS. Major complaint now, she has a back pain and a left anterior thigh pain. It is a progressive symptom and she is unable to walk. Quadriceps power is 3. Now that's a X-ray which shows a multi-level instability with the cord compression. And she needs a surgery of decompression and stabilization. This patient also had an osteoarthritis of the knee. Her right TKR was done 10 years back. Now the left is painful. Now if you look at the left knee, here medially there is a bone-to-bone arthritis, the tricompartmental, but there is no significant major deformation of the joint. But the patient is the biggest confusion. One doctor says, this is a knee surgery I will do. The other says, I will do the spine surgery. And that is how the patient keeps searching who is the person who will have a correct answer, and so second and third opinion. The best part is the same surgeon does the spine as well as the knee surgery. Probably there won't be much issues. So patient underwent a spine surgery. She was operated with a multi-level fixation and a decompression. The patient surgery was uneventful. Patient went home. The walking becomes better, and her knee pain, knee pain in the sense more of an anterior thigh pain, that also disappeared. Although the power was grade 3 only till that time. So this is a change which has happened. Now what is the orthoplasty surgeon thinks? He thinks the knee is arthritic, then because of that the quadriceps are not functioning, so they look weaker. Because of the pain, the muscles are weak. And at the same time, because it's an arthritis, patient is not able to walk. Where the spine surgeon, LCS is responsible simply because she has a radiation pain to the upper thigh or mid thigh, which is because of the high lumbar stenosis, and that is responsible for weakness and inability to walk. Now we have to find out which is the one which is giving more trouble to her. In this patient, we had gone with the fixation of the spine as a spine surgery first. So the condition causing more disability should be taken as a first case. So is it that always you do spine first, or you do knee also sometime first? So these are the different images I have put. These are all deformed knees, and for the patient to walk on this deformed knee is extremely difficult. So you have a varus knee, a valgus knee, significant. This deformity is not a minor deformity, they are a significant deformity. And you have windswept deformity, and even sometimes a flexion deformity of 30 degrees or more, it becomes difficult for the patient to walk. And therefore, these deformities should be given a priority over the spine surgery, provided spine is not like an emergency surgery. There is no progressive deficit which is happening. And only then, because that is happening, then probably you have to again go for the spine surgery first. A little deviation, it is more than whether to operate hip or knee or spine first. The important is not to miss any point, not to miss any diagnosis. Now, this was a 48-year-old female. She had a progressive low back pain. She had an old heel tuberculosis mostly, and a kyphosis lower dorsal spine, but no deficit. So patient has a pain, lower lumbar pain and around it. What is the interpretation? Because she has a significant kyphotic deformity, there is a hyperlordosis. And because of hyperlordosis, this pain factor is a mechanical factor which is responsible for her trouble. But when we went into details, looking at the gait and everything, what we found, she has a bilateral avascular necrosis of the hips. Now, this is a grade 3 Ficard and Arlett classification, and both the sides she needs a total hip replacement surgery. So, this can be easily missed if you don't look at even a hip and a knee, because that is also very important. So, what is the message I want to give? Between LCS and OA knees, spine gets a priority unless knees are grossly deformed and there is no spinal emergency. At the same time, whether you are a spine surgeon, hip surgeon, knee surgeon, you must examine all these three so that you don't miss any diagnosis. Thank you for your attention.